Although cervical cancer is less of a burden in the United States than it is in the developing world, it still accounts for nearly 13,000 cases annually. Cisplatin has been used both as a radiation sensitizing agent as well as the most active single agent chemotherapy. GOG 169 and GOG 179 compared cisplatin to combined cisplatin paclitaxel or cisplatin topotecan in women with advanced, persistent, or recurrent cervical cancer. The goal of this study is to perform a cost-effective analysis of chemotherapy agents used to treat women with advanced, persistent, or recurrent carcinoma of the uterine cervix. The regimens analyzed include single-agent cisplatin from GOG 179, the paclitaxel regimen from GOG 169, and the topotecan regimen from GOG 179. Current data available from published articles were used to estimate complications, recurrence rates, overall survival for analysis. In the cost-effectiveness model, grade 3 or 4 neutropenia, transfusion rates, recurrence rates, and survival were factored into the analysis. Medicare costs for chemotherapy agents, associated medications, infusions, and complications were used. A willingness to pay threshold of $50,000 for quality adjusted life year gain, as is generally accepted, was used for comparison. Costs that were not readily quantifiable were referenced from published literature. Cost effectiveness analysis and sensitivity analysis were modeled. The chart being shown is the cost-effective analysis graph depicting comparisons of cisplatin as a blue triangle, the paclitaxel regimen as a red square, and the topotecan regimen as a yellow diamond. The y-axis is total cost per patient in dollars, while the x-axis is the comparison of effectiveness. The analysis is based upon the lower survival for cisplatin from GOG 179. This graph demonstrates that paclitaxel is more costly than cisplatin alone, but is within reason with an incremental cost effectiveness ratio, or ICER, of $10,994 per quality adjusted life year gained. This is well below the widely accepted willingness to pay threshold of $50,000 per life year gained. The line connecting cisplatin and paclitaxel is the cost effectiveness frontier, or more specifically, the optimal choice based on the data given. In comparison, the yellow diamond of topotecan is surrounded by a green circle showing this combination is dominated. This means that the topotecan combination is more costly and less effective than the paclitaxel regimen. The ICER of topotecan is a negative $152,327 per quality adjusted life year. This busy chart demonstrates the effect that adjusting the cost of chemotherapeutic drug has on incremental cost effectiveness ratio per quality adjusted life year gained. The baseline rates used for cost are the 2011 Medicare reimbursement rates. The third column is chemotherapy cost alone. The fourth column includes associated medications and infusion cost, direct cost, and the fifth column adds attributable complications or indirect cost to the previous data. Examining the paclitaxel regimen compared to cisplatin alone, the ICER is $10,994 at baseline. Even if paclitaxel was given at no cost to the patient, the ICER would still be $8,870. Thus, the actual chemotherapy cost of generic paclitaxel is relatively minimal. In contrast, comparing the topotecan regimen to cisplatin, the ICER is $133,067 at baseline and drops only to $62,246 if the topotecan was given freely to the patient. Although eliminating over $7,000 in chemotherapeutic costs is not trivial, the ICER is still high because of how many more complications occur during therapy. This displayed chart demonstrates the effect that hypothetically increasing survival above what was found in randomized trials has upon ICER. Again, the baseline used is the 6.5-month survival found in patients receiving cisplatin alone in GOG 179. Comparing the paclitaxel regimen to cisplatin alone, if the overall survival were increased by 50% to 14.6 months, the ICER drops to $6,150. In contrast, comparing the topotecan regimen to cisplatin, the ICER drops only to $66,400 if the survival was increased from by 50% from 9.4 months to 14 months. The survival for patients receiving topotecan would have to be increased to 24 months to get under a willingness to pay threshold of $50,000 for quality adjusted life year gain. In conclusion, several points need to be considered. No one wants to be seen as rationing healthcare, but there are ways to decrease cost but actually give the best care to all patients. The paclitaxel regimen is a cost-effective alternative to single-agent cisplatin, but should only be adopted if it is truly thought to have a significantly increased survival. The topotecan is not a cost-effective alternative because of its increased cost. Even if the topotecan were given freely, it would still not be cost-effective because of the substantial increase in complications. New platinum or non-platinum-based therapies should be studied in both randomized clinical trials and in cost-effective analysis. Much higher survivals must be found to justify increased cost and potentially increased complications, even if the survival increase is found to be statistically significant. Thank you.